Good morning, I'm Jaehoon from Dongguk University Ilsan Hospital. And today I'll be discuss the topic central to cardiovascular pathophysiology, hypertension and arterial stiffness, causal effect. Hypertension is a well-known significant global burden. Hypertension affects over 1 billion adults globally and associated increased risk of cardiovascular, cerebrovascular, and kidney disease. And it is also well-known leading cause of death worldwide. As Professor Park presented, the arterial wall is composed of 3 layers: intima, mainly endothelium, media, smooth muscle and elastin, and adventitia, which is mainly collagen. The media is primarily made of a smooth muscle cell and elastin, which is key element of arterial compliance. And over time, the reduction in the elastin content and an increase in collagen leading to stiffening of the arteries. And also, the chronic inflammation and oxidative stress are thought to play a significant role in the pathophysiology of arterial stiffness. As time goes by, besides the mechanical stress, endothelial dysfunction, and other risk factors like dyslipidemia, diabetes, and smoking accelerate arterial stiffness. In healthy subjects, elastic arteries buffer the pulsatile output of the heart, ensuring steady peripheral perfusion, a phenomenon known as the Winter-Castle effect. And with arterial stiffening, this buffering capacity is lost, and finally resulting in higher systolic pressure, lower diastolic pressure, and increased pulsatile load to the end organs. Stiffening is not merely mechanical; it's a biological process involving elastin degradation, extracellular matrix, and vascular smooth muscle cells, phenotypic switching, and chronic inflammation and calcification, like this. We can measure arterial stiffness with a pulse wave velocity, which is considered the gold standard. It measures the speed at which the pressure wave travels along the artery tree, and the faster pulse wave velocity means steeper arteries. Among them, carotid pulse wave velocity is considered the gold standard for non-invasive assessing aortic stiffness. It measures the transit time of the pulse wave between the carotid and the femoral artery, which is composed of mainly elastic arteries, and is a well-known, strong, and independent predictor of cardiovascular events and all-cause mortality. Other indices include anchor pulse wave velocity, which is more convenient and easier to perform. So it's more practical, and other things are augmentation index and central pulse pressure. Among them, Barker pulse wave velocity is nowadays we can use it very easily, and however, it has some limitation because it measures between brachial and anchor pulse wave, so it includes not only the central but peripheral stiffness. So brachial and pulse wave velocity may better represent the total resistance of value than carotid femoral pulse wave velocity. Arterial stiffness increases with age and is accelerated by the hypertension, diabetes, and chronic kidney disease. And it is associated with widened pulse pressure, left ventricular hypertrophy, and target organ damages. The classical view posits that chronically elevated blood pressure damages the vessel wall via mechanical strain, and endothelial dysfunction, and loss activation, and oxidative stress, collectively accelerating stiffening and remodeling of arterial walls. The vascular smooth muscle cells respond to increased mechanical load by switching from a contractile to synthetic phenotype, and they secrete steeper external matrix components and contribute to the hypertrophy and calcification, locking in the stiffening of arterial walls. This initiates a vicious cycle. Hypertension induces structural change that promote the stiffness, and the stiffened artery further aggravates blood pressure by altering hemodynamics, and this bidirectional feedback group is central to disease progression. However, recent accumulating evidence suggests that stiffness can precede hypertension, And experimental and clinical studies now point toward arterial stiffening as a causative factor, not merely a consequence like this. In elastic arteries, the forward pressure wave from the artery is reflected back from the peripheral sides, and if stiffness arteries, the reflected wave returns to aortic much faster than normally. The reflected wave arrives in diastolic phase, but however, in stiffened arteries, this reflected wave arrives in later systole, so that's summating with the outgoing pressure wave. And this phenomenon disproportionately increased augments central aortic pressure and widening pulse pressure. So like this, you can see. This stiffening arteries cause hypertension is have several evidence. One is the longitudinal evidence from the Framingham Heart study. Framingham Heart study showed that a higher baseline carotid femoral pulse velocity predicts the incident hypertension over 7.8 years, and even after adjusting baseline blood pressures. So this provides strong support to hypothesis that aortic wall stiffening anteceded and contribute to the development of systolic hypertension. And similarly, the F1 longitudinal study of parents and children shows that adolescents with higher pulse velocity at age 17 had greater hypertension of risk at 24. So this means the temporal relationship provides a strong evidence for a causal pathway where stiffness precedes hypertension starting in early life. And a genetic model and experimental model also shows the evidence. In genetic model, with Williams syndrome children, their arteries are more stiffened, and then the hypertension develops. And diet-induced obesity model shows that arterial stiffening occurs before the onset of rising of systolic hypertension. This is not a chicken or egg question. It's a positive effect where hypertension and arterial stiffness perpetuate with each other like this. As I said, the arterial stiffness can hypertension, and hypertension also cause arterial stiffness. The vicious cycle like this, high blood pressure leads to endothelial dysfunction, where stress and inflammation and elastic activation that cause elastin degradation and collagen diffusion, and vascular smooth muscle changes. Then it results in increased arterial stiffness, which leads to early wave reflection and increased systolic, central blood pressure and pulse pressure, then which leads feedback to worsening high blood pressure. And aging is most powerful and non-modifiable factor risk for accelerated this cycle. With aging, elastin fibers naturally degrade, and this leads to progression of age-dependent increase in baseline stiffness, making the arteries more susceptible to the effect of blood pressure. After age 50 or 60, diastolic blood pressure falls while systolic pressure continues to rise. This is a hallmark of a dominant level of arterial stiffness. With aging, so once liver healthy state, natural stiffness gradient exists. However, in aging and hypertension, the central arterial stiffness disproportionately faster than peripheral arteries. In consequence, this stiffness gradient is reduced and even reversed. This leads to structural damaging in high flow organs with like a high in brain, white matter hypersensitivity and cognitive decline, and in kidneys, glomerular squeeze and reduced GFR, linking central aortic stiffness to end organ dysfunctions. In ESRD patients, the extravascular classification lose a stiffness gradient and very high pulse rate velocity, and these are all strong predictor of mortality. And in diabetic patients, advanced glycolation end products crossing collagen and making it steeper, and it causes also the endothelial dysfunction, and synesthetic stiffening even in the same blood pressure level. This brings us to vascular aging. Some individuals age prematurely, early vascular aging, while others maintain elastic despite age and risk factors. We goal is supernormal vascular aging, and ProSwift helps personalize risk beyond chronic age. Measuring arterial stiffness enhances the risk stratification, especially in those with borderline blood pressure, and it explains isolated systolic hypertension in the elderly, and it may guide therapy intensity of drug class selection. As I previously said, cardiac pulse wave velocity is independent to predict cardiovascular events and mortality, adding it to risk score like framing risk scores, significantly improve the risk classification, and especially in younger patients. And higher pulse wave velocity is associated with worse cardiovascular outcomes. Besides hypertension, lots of mechanisms are involved in arterial stiffness. Besides aging, hypertension, dyslipidemia, dysglycemia, and adverse tissue dysfunctions. So, how we can break this cycle? The lifestyle intervention can break this cycle, like weight loss, reduced sodium intake, aerobic exercise. In the study shows that meta-analysis shows that weight loss improves pulse wave velocity significantly, and sodium reduction also reduces both blood pressure and arterial stiffness. And aerobic exercise improves arterial compliance even independent of blood pressures like this. And while all hypertensive lowers the stiffness functionally, among them, RAS inhibitor may reduce the fibrosis and extracellular ECM accumulation, and MRAs have shown benefit in chronic kidney disease. And statin also may act through anti-inflammatory mechanism, and SGLT2 inhibitor and the GLP-1 agonist may reduce the stiffness, improving cardiovascular outcomes. To conclude, hypertension and arterial stiffness form a vicious, mutually reinforcing cycle. Measuring arterial stiffness with tools like pulse wave velocity gives us a crucial insight into vascular health and enabling early intervention. Moving forward, a dual therapy approach controlling blood pressure and directly targeting arterial stiffness may be essential to truly reduce the cardiovascular risk and break this vicious cycle. Thank you for your attention.